Welcome everyone to IsisParenting's breastfeeding webinar and chat. My name is Nancy Holtzman. I'm a mom and baby nurse educator, board certified lactation consultant, and board certified in pediatrics. I'm here at IsisParenting's home office outside of Boston, Massachusetts. And with me today in the moderation role is Hillary, who's one of our programming planners. Thank you, Hillary, for being with us. And today we are going to talk about the early days of breastfeeding. Last week I covered home from breastfeeding in the hospital, so days 1 and 2, the time immediately after birth, and the hospital experience. And this week we're going to cover what happens when you go home, because for many people that's really the tough part. And we'll cover all of the various reasons why, but a lot of the reason has to do with the fact that most people leave the hospital before their milk has actually come in, and the whole terrain of the breast changes, and it can be challenging to both manage engorgement and latching difficulties, which sometimes go hand in hand, and then all of the other things that we'll touch on one by one. So last week we did talk about the hospital experience, and in the perfect world scenario, your baby is born full term, alert, and healthy at birth, and so are you. And the baby hopefully can come skin to skin and breastfeed, either latch or at least lick, nuzzle, familiarize himself or herself with the environment, the mom's environment, and then hopefully have an early feeding, and then perhaps take a nice long nap, and then for the next 48 hours or so, eat intermittently, suckling at the breast, getting some colostrum, learning how to breastfeed mom, getting some support, learning different positions, learning some nipple care and latch techniques so that she doesn't end up with sore or damaged nipples, etc., etc. And again, in that perfect world, you go home and there's some transient, temporary bumps in the road that you overcome, and then before you know it, you have a beautiful little girl like this one, who looks to me to be about 4 months old or so, smiling up at you at the breast. So that's what we'd like to happen. And what does that look like when you do go home day 3 through day 7? This is what we would hope happens. So your milk will begin to come in more fully, and I like to remind people that you do have milk. Colostrum is early milk, so your milk is already there, but it becomes more copious, larger volume, and then also more dilute, so less thick and yellow, and more yellowish milky, and then finally more mature milk, which is whitish or bluish milk. So the milk does come in more fully, sometimes around day 3 or 4 or day 5 or 6, depending on if you're a first-time mom, second-time mom, vaginal birth, or C-section. But of course, we don't want the milk to come in too fully because engorgement is uncomfortable. And so that transient fullness hopefully can be avoided or handled with relative ease. We'll go over all of these in more detail. What we would like to happen is to hear that the baby's latching at most feeding attempts, and this is why I usually recommend that you try to feed your baby 8, 10, 12 times in 24 hours, because as we all know, each feeding is not going to go smoothly. So there will be times where you try and try and try to get the baby to successfully latch, and it just doesn't seem to happen, and then, there's tears, and the baby cries too, and it's just kind of a mess. Or the baby comes to the breast and sucks a little bit and then promptly falls asleep, and you really can't rouse her, and so that feed doesn't really seem to be very effective. So when you are trying to feed your baby 10 times in 24 hours, even if a couple of them don't work out so well, it's not a tragedy, because you're still getting 7 or 8 good solid feedings in there. If you're only trying to feed your baby 7 or 8 times, and a few of them don't work out so well, then your baby may only be getting marginal volumes of colostrum or milk when he or she does come to the breast. Other things we want to see happen is we want there to be milk transfer. So once your milk is in more fully, the breast feels firm before you feed, and then it should feel a little bit softer after the feeding. Hearing some swallows, and swallows sound like a little puff of air through your baby's nose, or a little soft K sound in the back of the throat. I'll try to imitate it. That's kind of what swallows sound like. Usually you'll see milk kind of pooling in the corners of the baby's mouth. This is a beautiful photo here, I believe this baby's name is Amelia, and I think she's probably just about 10 or 12 days old today. So this baby is right, this picture's right hot off the press. This is a very recent addition. It's a small picture, but at the bottom of the baby's mouth is a nice droplet of milk. So this baby is, as we call, milk drunk. So baby is crashed out after a good meal. So you want those signs of milk transfer. The breast is softer, you hear swallows, you can see milk at the corners of the baby's mouth, and then the baby may be content for an hour or two. There are periods of time where your baby may want to cluster feed and seem like they just want to doze at the breast suckling and not come off at all. And then there may be times where you can wrap up your baby and your baby may actually sleep for 2 or 3 or even 4 hours and then wake up and want to eat constantly. So it may not be like a clockwork every 2-hour feeding, but basically if you feel like the breast gets softer, you think the baby's swallowing, the baby seems content for an hour or two between feedings sometimes, and you begin to see changes in the diaper output, those are all very good signs of milk transfer. And then another thing that we want to happen is for mom's nipples to be hanging in there and doing okay, hanging on there, because certainly we've all seen nipples that are just not comfortable and quite damaged. So that's always a sad thing to see. And although tender nipples may be fairly common, quite common, especially for first-time moms, damaged nipples or severe nipple pain that makes you dread the next feeding and almost want to throw in the towel, those things are not normal and not to be expected. So what is normal is perhaps some latch-on pain where the baby latches on and you may need to take 10 deep breaths and count to 20, but then the rest of the feeding should feel like a gentle tugging sensation that is not painful. Now, if you're still, day 3 or day 5, it may be that your uterine cramping is more painful than your nipples. But again, severe nipple pain is not normal and should be looked at, addressed, and hopefully improved. And we'll talk about sore nipples in a minute. Other things we want to see happen, good signs, are changes in the diaper. So depending on when your milk comes in, you're going to see first an uptick in the baby's urine output. And again, the diaper contents are a clear representation of what is going in. So what comes out the other end helps you understand what's going in through the mouth. And if you're supplementing with whether it's formula or sugar water, which should never be used really, I won't really get into that, but I don't think any hospitals really are using sugar water anymore for jaundice and so on. But I can certainly imagine at home certain baby grandmothers saying, give the baby some sugar water and so on. But my point is that if you're not clouding the picture by giving the baby anything else, then what's coming out the diaper is clearly what's coming in through the breast. So even if you're expressing milk and then feeding it to the baby in a bottle, it's hard to tell, and that's not necessarily a bad thing. Sometimes there's a reason for that. But my point is that if the baby is only nursing at the breast, then what's coming out the diaper is a very good indicator of how things are going. That's my point. So you do want to see an uptick in the urine, in the wet diaper count, starting around day 3 or 4, which is typically when milk is starting to become more abundant, and you should see 3 or 4 wet diapers. So typically you'll see wet diapers on day 1 after birth, and then day 2 they start to slow down, and depending on when mom's milk is coming in more fully, day 3 may be a fairly dry day because the baby is born quite hydrated and pees out quite a bit of that hydration during the first 24 hours. And then, by day 3, their pee is basically, kind of what's going in. So as soon as there's more milk going in, then you'll start seeing more pee coming out again. So that's usually around day 3 or day 4. You'll begin to see more wet diapers, and then by day 5, 6, and 7, typically mom's breasts are feeling quite full then, and the baby is getting more milk, and you will see the diaper count pick up. And if you have a very, very young baby, like day 3, day 4, and it's hard to tell if the diaper is wet or not, 2 good tips. Take a little square of tissue or toilet paper and place it between the baby's genitals and the diaper, and it will be easier to tell if it's saturated with urine, because if you're using petroleum jelly on the diaper region on your baby's bum, sometimes it's hard to tell if the diaper is actually wet or if it's petroleum jelly and so on. So if you put just that little square of tissue over the baby's genitals between that and the diaper, it's pretty obvious if the baby's urinated on it or not. And that's how you can tell some wets. Another good tip is to take the used diaper in one hand and a brand new clean diaper in the other, and then you can kind of make that comparison. It's easier to feel if the used diaper is a little bit heavier than the other one, because really a baby's urine output is just 1 or 2 teaspoons of liquid, and that's not a lot. It doesn't weigh a whole lot. Another indicator, just so you know, and you could practice this at home, is if you take a modern disposable diaper and if you put a tablespoon or 2 of water in there, you'll notice when you squish it with your fingers, it feels a little bit jelly-like, like a gelatinous jello in there, and that's because the gel crystals absorb the liquid, and you'll see what that feels like. You can also tear open the diaper a little bit and see what those gel crystals look like, because you will at some point see one of these gel crystals on your baby's genitals, and this way you will not freak out and think it came from the baby. Call the pediatrician, who will send you to the emergency room. I have seen this happen. It's outrageous. But gel crystals come from little tiny tears in the diaper, and sometimes do get stuck to your baby's genitals, and it didn't come from your baby. Okay, poop. So what we do want to see happen is by day 3, the baby hopefully has pooped out most of their meconium, which is a meconium plug. It's black and tarry and sticky and hard to clean off, which is why we coat the baby's bum with petroleum jelly. And then typically when your milk is starting to flow and the baby is getting milk, you'll see transitional poop, and that is the meconium mixed with the beginnings of more mature breast milk poop, and that will look greenish, and then gradually greenish yellow, and then finally yellow. And so my range of mustards here is just an approximation of the various types of breast milk poop that's normal, and if you would like to learn more about poop, I have a whole webinar just on baby poop. But we would like to see the end of meconium by day 4, and yellow or breast milk type poop by day 5, and then by day 7, the baby should be having at least 3 or 4 moderately sized yellowish diapers, poop diapers. Okay, so here's where we start running into some snags, because these things happen. And sometimes these challenges crop up and are very distressing. It's when you're home with your baby and it's either time to feed, you're feeding, or you just finished feeding and you're already thinking ahead to the next feeding. There's no getting away from it. There's no break. Make no mistake, your first 2 weeks at home are going to be entirely focused on feeding your baby and trying to keep your baby clean and content. Not that that changes much after 2 weeks, but just the feeding part itself is overwhelming. Getting feeding up and running and established, there's not a whole lot of time for anything else. You should take care of yourself, you should eat, you should rest, manage the laundry, and that's about it. So everything else, hopefully, other people can help you out with, including siblings. These are the areas that we're going to talk about in more detail right now, because these are the key issues that parents are challenged with. Engorgement. So let me clarify that engorgement is not about the breast full of milk, because sometimes when people are rock hard engorged and they sit down for 30 or 40 minutes at a breast pump, which is not the thing to do, by the way, because it can damage your nipples, they're surprised that they only express a small volume of milk. And that is because what's going on with the breasts during engorgement is it's the hormone shift that creates the beginning of the stage of lactation sends lots of blood flow to the breasts. And the blood flow to the breasts pulls extra what's called interstitial fluid. So it pulls a lot of the fluid from the body to the breast. And so your breasts are actually hot and swollen with blood flow and edema, swelling, but not full of milk. So all the hardness and firmness is not milk in there. It's not like there's a gallon of milk in each breast, even though it may feel that way. And in particular, if you had an epidural and you had bag after bag after bag of IV fluid run into you, and day 1 or day 2 after you delivered, your ankles were all swollen and puffy. Let me know if that sounds familiar to anybody. Usually around day 3 or day 4, that fluid shift is going to end up in your breasts. So if you had a lot of IV fluid and a lot of fluid overload and swelling right after the time of birth, you can expect that you're going to see that in your breasts as well. So there is milk in the breast, but all of that engorgement and swollen tissue is not milk. The breasts are very uncomfortable, can feel rock hard. And the key take-home message here is that it's very hard to latch a baby when a breast is truly engorged. And my analogy is imagine your baby trying to latch on to a firm beach ball with an M&M glued to it and then the whole thing covered in olive oil. And that's what your baby's trying to latch onto. If they're lucky, they'll be able to clamp their gums around the M&M and hang on for dear life. And I think we all know that, number one, that's not how you latch on, and number two, it's going to make you damn sore. But when the breast is firm, like that beach ball, and all slippery without that olive oil, there's just not a whole lot to latch onto. And that's why softening the breast and helping draw the nipple out and maybe even getting a little bit of the milk flowing ahead of time will make latching so much easier. So how do you handle engorgement? You can use warmth, like a hot washcloth or a shower or a heating pad, just before breastfeeding, and that does bring a little bit more blood flow to the area, but then you may be able to use some manual expression or a manual pump to compress down around the areola, which can help soften the areola and make the nipple a little bit more extendable, or using a manual pump or an electric pump carefully can help draw the nipple out and maybe get a little bit of milk flowing, which will make it a little easier for the baby to latch on. So essentially, you want to try to soften the breast tissue a little bit, draw the nipple out, and get the milk flowing so that the baby has a easier time latching. After feeding, and then during feeding, you can use gentle massage. After feeding, you really, really want to be using cold packs, ice packs, and bags of frozen vegetables like peas and corn are perfect for this. So what you probably want to get is just maybe 6 bags, small bags of frozen vegetables that you just use and refreeze. They're the perfect size. They can mold for under your armpits and under your breast, so you can just stack, lay 3 of those around each breast, and you will be in heaven. It will feel so good, and then you just throw them back in the freezer afterwards. So you want to use ice after and in between. Keep taking the ibuprofen as long as that's safe for you, and your doctor has suggested ibuprofen after childbirth, which is very common, 600 milligrams every 6 hours with a little food or snack. And that is an anti-inflammatory that can also help with the discomfort, any little short-term fever, but also as the inflammation to the breast can help the milk flow a little bit. You want to soften the breast before the baby comes to the breast to make it easier to latch. And if you are rock solid and uncomfortable, you may hear people say, oh, never pump when you're engorged. It will just make the engorgement continue or make it worse. And no, you don't want to go overboard with pumping, but sometimes if pumping is effective and it's making your breasts a little bit softer and more comfortable, pumping once or twice is it's not the wrong answer. So if pumping is helping, just you don't want to go overboard. You don't want to be pumping 4 and 5 times a day and pumping off lots of milk and perpetuating that. But again, don't hesitate to pump once or twice if it's giving you relief. Okay, look at this beautiful one. I think Megan's in the room right here today. Look at that gorgeous, beautiful latch. That baby's lips are flanged out. That has a wide open mouth. And latching does take patience and practice. So I'm just getting into some of the issues now. So engorgement is an issue. Difficulty latching is a very real issue when moms go home, because sometimes in the hospital there's lots of hands there to hold and to help and to position. The breast is softer. Maybe the baby is a little bit more alert. Sometimes you go home and the baby is in a very sleepy mood for a few days. So some things that can help. Real skin to skin, which is no bra on mom, bare chest, the baby in only a diaper and perhaps a hat, and then you can put a towel or a shirt or a warm blanket over the both of you. But in that environment, the baby will sleep deeply and then can rouse and sometimes even look for the nipple herself. You want to feed the baby when the baby is alert and starting to wake, and not try to feed the baby by the clock. In other words, not just wake the baby up because it's been 3 hours, because if the baby is in a very deep sleep, she's not going to be happy being woken up, and she won't actually be woken up very easily and will still be groggy and not perform well at the breast. So wait until the baby's in a light sleep stage and then try to arouse your baby and work on latching. Then we talked about why you want to soften the breast and the areola to draw out the nipple and help the baby have a little bit something easier to latch onto. Sometimes if you manually express a few drops and dab them on the baby's lip or put them around the nipple and areola, it perks the baby up a little bit. They smell and they taste the milk and they get a little bit more interested. Positioning tips and latching tips are very different for different moms. I have webinars that cover both of those in more detail. Let me see what the next slide is if I put something on there. No. Okay. But, and I went over some of this last week too. You just want to make sure that the baby's in good alignment so that the nose and the belly button are lined up. You don't want to be nursing with your baby laying on his or her back with the head turned toward the breast. It's very hard to swallow when your chin is over your shoulder. So the nose should be in a straight line with the nipple, and the head is better off tilted slightly back rather than curled slightly forward. Don't let your baby chew or slurp their way onto the nipple, and if you latch them and it pinches and doesn't feel right, even after you've counted to 10, break the suction with your finger and try all over again, because if you're just so grateful that the baby is latched on and they're sucking just on the nipple and they're making you sore, they can create damage that you will regret for the next 2 days. Patience and practice. Try frequently because not each feeding will be successful, like we talked about, and many moms are sent home from the hospital with nipple shields, and perhaps some of you were. If you are sent home with a nipple shield, make sure that you have some breastfeeding support lined up at home, a lactation consultant, or a plan to return back to if your hospital has a drop-in breastfeeding group or something like that, because a nipple shield is an intervention and people shouldn't be sent home with it. It's kind of like somebody coming into the emergency room with severe leg pain and they get handed a pair of crutches and sent out. So it doesn't solve the problem, it doesn't answer the issue, and it doesn't address what's really going on. So a nipple shield may help the baby latch easier, but that's not the end of the conversation. Also, if you're using a nipple shield, I am one of those lactation consultants that really does think insurance pumping is beneficial, particularly in the very newborn stages. So insurance pumping means, in this case, perhaps 4 times in a 24-hour period after breastfeeding, you're double pumping for about 10 minutes. So just to really make sure that you're fully initiating and maintaining that milk production. What about the baby who won't latch at all? Because we've talked about some babies who are difficult to latch, or maybe you can only latch the baby on one side but not on the other, or maybe you can latch but only if there's a nipple shield, et cetera, et cetera. And then what about the baby who will not latch at all? And that is the situation where you really do need a contingency plan, and we'll talk about that toward the end. But essentially, one way or another, obviously the baby needs to be fed, and one way or another, you need to initiate and then maintain milk production. So if the baby will not latch reliably, then or will latch but not transfer milk, then you still need to be stimulating full milk production 8 times in 24 hours by expressing milk, probably using a combination of massage and the double hospital grade pump, and then feeding the baby what you're expressing in an alternate method, whether it's using finger feeding or a bottle. There are some other methods too. I'm not going to get into that in this webinar. Okay, so ye old sore nipples, another unfortunately common occurrence, sore nipples and damaged nipples. If a nipple is truly damaged, if there is a chunk taken out of it or a big crack across the surface, very commonly someone will walk into a room, look and say, oh, latch looks good. Sometimes you'll see moms with very severe nipple pain or nipple damage, and mom will say, well, so-and-so looked and said that the baby's latching well. The latch and the position both matter. You really can't tell exactly what's going on just by taking a quick look. And I love this picture both because the baby is adorable and beautiful, but also just by looking, you really have no idea what's going on inside the baby's mouth. Here you can't even see the baby's mouth, but you can see a latch that looks nice from the outside. And the baby is essentially clamping on mom's nipple. So there's a lot more assessment that has to happen instead of just a quick look if there's a lot of pain and a lot of damage. But other things that can cause pain and damage are also mom's anatomy and the baby's anatomy. So a skilled lactation consultant really needs to weigh in on this type of thing and check to make sure Is there a tongue tie? Is there something going on with the baby's oral anatomy, like a very, very high palate, which means that a certain type of a feeding position is going to be a lot more comfortable for mom than the standard breastfeeding positions that you may have been shown in the hospital. Does mom have a very flat nipple or inverted nipple? Here are some things that we can do to help that situation, and so on. Meanwhile, we certainly want to get that nipple healing and feeling better as quick as possible. And keep in mind that a damaged nipple is going to be sore. So you could have a crack or a blister or a sore nipple, and even though you're now latching the baby correctly and the positioning is improved, it's still going to be sore for a little while it's healing. And my analogy on that is, imagine you took a wipe out on your bike and you totally skinned your knee, and your knee got really road burned. Well, the knee is still going to hurt for several days as it's healing, even though you're not continuing to damage the knee. Just walking and bending and so on, it's going to be uncomfortable because the skin integrity is damaged. And particularly the nipple, which is a sensitive area of the body that has not had a whole lot of use before breastfeeding for you, very likely, and the fact that the baby is going back there 10 times a day, it can be sore. So these are some things that can help. The hydrogel pads and TheraShells, which I really love. These are like little plastic cups or cones that have air holes that sit over your nipple, under your bra, in between feedings, and they allow your nipple to be out in space with air circulating around and nothing pressing on them. So it can really help promote healing, particularly if there's a crack at the base of the nipple, because as you can imagine, when you put your bra pad on and then you secure your bra up, it smushes the nipple into the breast tissue and kind of sometimes folds it. If the nipple is very long, it kind of folds the nipple or squishes the nipple in, and that gets in the way of both comfort and healing. So these TheraShells, breast shells, they're also called, are very good to promote healing and comfort. Lanolin can be useful, but it's not a cure-all, and also Apno cream. Many people are given Apno cream in the hospital, and that can be very helpful as well, but those things aren't cure-alls. So if the nipple pain, if the nipple damage is not getting better, please do call your lactation consultant, call your pediatrician's office, see if they have a lactation consultant or a referral for you. Of course, if you are in Boston or soon in Dallas, Fort Worth, or Atlanta, all of our centers have lactation consult offices, and we see clients in our centers 6 or 7 days a week. Okay, another very common issue is the baby who goes home and is very, very sleepy and ineffective eating. And another thing to think about, remember, is that, again, that 10, 12 feeding attempts in 24 hours, because you're exhausted. And sometimes moms will say, oh, she's such a good baby. She sleeps so well during the day. If a baby is sleeping for 3 and 4 and 5 hours again and again, it can sometimes mean that the baby is getting jaundice, which makes them more sleepy. They don't have a lot of energy. They don't have a lot of calories, and so they're sleeping because they're a little bit weak. Which is not to say that if your baby has one 3 or 4 hour period, it's a bad thing. Of course not at all. But for a very young baby, we want them to sleep, sure, but we also want them to eat effectively. So sometimes you do need to wake up your baby, and again, watching the baby for light sleep stages. So when they're sleeping very, very, very still, and you pick up their arm and drop it, and it just flops, their face is very still, no little twitches of the mouth, and so on. That's a deep sleep, and I would probably just let them be and check again in 10, 20 minutes, because they'll cycle through. An infant sleep stage is about 30 to 50 minutes or so. So they'll cycle through into light sleep, and light sleep is the best time to really try to rouse them. That's when you want to pick them up, turn the lights on, talk to them, touch them, undress them, change the diaper. These are all little ways that you can wake them up. And when feeding them, it's very easy for a baby in a rocking chair, once they've got a little bit of milk in their belly, to fall asleep. It's all warm and cozy, and even the breast milk itself has a hormone in it that makes them sleepy. So you really want to try to keep them active and awake when they're feeding, and annoy their little fingers and toes, pick and prod and poke gently, nudge them a little bit. You don't want to bother their head very much. Like you don't want to touch their hair and the head where a hat would go. But other parts of the body you can switch and gently, gently nudge a little bit. So you're looking for non-rhythmic, non-predictable movement. Rocking, patting, those things are very rhythmic and drowse-inducing, and that's not what you're looking for here. Okay. Jaundice is very common, and in fact, the most common form of jaundice is called normal physiologic jaundice because it is normal. So I did put don't freak out at the bottom here because even if your baby does have jaundice and you do need to be returning to the hospital to have their bilirubin level checked every day or every other day for a few days in a row, please don't think that this is a crisis situation and that something devastating is happening. Your pediatrician has to monitor this. They're covering their butts a little bit to make sure that it's not going to get worse and worse and worse without them being aware of it. But it's very common for babies to become jaundiced. Most jaundice resolves within, the bilirubin levels resolve typically within a week to 2 weeks. A different type of jaundice called breast milk jaundice sometimes takes much longer to resolve, 3 or 4 or 5 weeks. One thing to know is that if your baby's skin tone is a little bit yellow, first of all, a healthcare provider or someone that sees a lot of babies will notice that. You as a mom who may not see a lot of babies and may not be in the world of pediatrics, you actually may not notice that your baby's a little bit yellow because you don't know otherwise that that's not a typical skin tone. But yeah, we look at the face. Usually jaundice, the face is yellow first, and then it creeps down the shoulders and the trunk to the nipple, and then the belly and so on. And then also the whites of the eyes can look a little bit yellow too. But it's normal for a baby to be a little bit jaundiced, and the key thing is that your baby is eating. The best response to jaundice is to feed, feed, feed. The more the baby eats, the more the baby will poop. And the more the baby poops, the faster they poop out that meconium, and the more poop they're doing, the better their bilirubin counts will be the next time it's checked. Because bilirubin binds to the bowel movements and is passed out that way. Meconium sits in the colon, and a chemical from the meconium is reabsorbed and makes the jaundice worse. And so clearing out that meconium and then pooping and pooping and pooping is very good for jaundice. Sunlight, it's very difficult to recommend sunlight to new parents because we don't want a mom, at high noon in Arizona in July to put her baby out in the sun for an hour. And it depends on what kind of glass is in your windows, whether or not putting your baby in the sunny window is going to matter or not. And then, of course, again, what if you put your baby in the sunny window and it's, brutally hot there, and etc. But, if it's reasonable, if the temperature and so on is reasonable and you can go sit outside on your front steps with the sunlight shining on your baby's face for 10 minutes at a time, use your judgment about that or ask your pediatrician. But that's what we used to recommend with sunlight. Now, again, it's challenging to recommend sunlight. In severe situations, phototherapy is used, and that is unfortunate. That might mean you need to go back to the hospital for 2 days so the baby can be under the billy lights. But at any rate, know that jaundice makes your baby sleepy, and a sleepy baby is harder to feed. And when a baby is harder to feed, they're taking in less milk and they're pooping less, and so they become more jaundiced. And a jaundiced baby is harder to feed because they're sleepy, etc. So you can see how this becomes a vicious cycle. You interrupt it by feeding, feeding, feeding. And if your baby is not transferring milk well at the breast, then you may need to be pumping, 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 and feeding the baby the milk another way, because once they start getting a fair amount of milk into them and they start pooping up a storm, they're going to clear that jaundice, that bilirubin level will drop, they will be more awake and alert. Okay. Oh, look at this gorgeous baby. Weight loss. So this one's another tricky one because 10% weight loss is not unusual, and 12% weight loss is not devastating, especially if it's about to turn around. So there's so many different connotations that are involved with this. Obviously, the first thing we want to know is there transfer of milk going on? So if you go to the pediatrician on, day 4 or something like that, day 5, day 4, and they say, oh, the baby's lost more weight, it's 11%, this is bad. Maybe your milk has just come in the night before, 12 hours before, and maybe now the baby is starting to perk up and eat better, and so on. So, and if the pediatrician says something like, "Oh, I don't like it," the weight's down since discharge, you can say, my milk's coming in, she's feeding so much better, she had a big diaper this morning, let's see how things go tomorrow. Or, come back for another weight check in a day or two. Most pediatricians they're not gonna say, oh, just because her weight is down 12%, you need to start giving an ounce of formula after every breastfeeding session. They're gonna say, well, what's going on? And, are we about to turn that corner? Because there's always a lowest weight before it starts climbing again. If a baby is born at 8 pounds, 10 ounces, that baby is probably going to go down. The baby may be discharged from the hospital at 8 pounds, 1 ounce, and the next day at home, the baby actually may be 7 pounds, 14 ounces, and then you go back to the hospital for the weight check the next day, and baby is 7 pounds, 15 ounces. So the baby actually, went home, hit the lowest weight, has already turned the corner. Nobody knows really, that the baby's already turned the corner. They just see that the baby is still down a couple of ounces from the discharge weight, etc. But always know your baby will lose weight before they gain it, and we like to see babies back at or above their birth weight by 2 weeks, preferably sooner. But that's kind of the standard is to say back to birth weight by 2 weeks. If it's in that ballpark, that's a good thing. So let's see. Other things to think about are, is it day 5 and day 6 or day 4 and the baby is screaming and there's been no breast changes for mom? Milk is just not coming in, and let's figure out why. This is something that you would need to talk with your lactation consultant about. BFAR, that stands for breastfeeding after reduction. So is there previous breast surgery, a breast reduction surgery, that can impact milk coming in and milk production sometimes. Retained placenta, if there's still a lot of cramping, and pardon me, but big chunks of placenta coming out from a vaginal birth, that can be a problem. Retained placenta still continues to produce estrogen and gets in the way of the onset of copious milk production. So that's something else we like to rule out. Certain hormonal and endocrine issues, having a diagnosis of PCOS, which I'm sure half of you in the room do, is not an indicator that you will have problems breastfeeding or with milk production, but it can be a pink flag that we look at if there are problems. Anatomical differences, that's a politically correct way of me saying rarely, but sometimes some women have underdeveloped milk-making tissue in their breasts, and characteristically widely spaced breasts, tubular breasts, or a marked difference between the left and the right breast are markers for this. Again, it doesn't mean that if you have these types of anatomical differences, you will absolutely have challenges making milk, but you could. And certainly if someone is having difficulty making milk, then that's one thing we would look at is, what is her breast tissue looking like, and did she have changes during pregnancy? Did you have that increase in breast size and tenderness during the second trimester, and so on. Excessive blood loss. So if mom had a postpartum hemorrhage or severe bleeding during childbirth, there's something called Sheehan syndrome, and so sometimes that actually can impact onset of milk production. If there is weight loss, you just want to get nursing. If the baby is not transferring milk or is too sleepy or jaundiced, then it's nursing and pumping and feeding the baby the milk a different way. Follow the baby's diapers. Again, there could be weight loss, but once you start seeing, maybe it just took a little bit longer. Maybe it's day 6, 7, and 8 that you're starting to see many more heavy, wet, and poopy diapers. But that's a good sign and things are going to turn around. Be in touch with the pediatrician. They may want to see you each day or every other day for a weight check. That's okay. Overinflated birth weight. So again, in that scenario where mom had an epidural and had many, many liters of IV fluid during labor, sometimes babies are born with a little excess fluid on board from that. They're a little bit overhydrated. And so say your baby was kind of sort of supposed to weigh 8 pounds, 10 ounces, but it turns out when not that you would know, but it turns out that your baby was born weighing 8 pounds, 15 ounces, and they were just a little fluid overloaded. And so the first day of life, they peed out 5 heavy wet diapers. Let me tell you, on day 2, that they're going to have lost more than 10% of their weight. But it's not real. It's not fair to judge them on excess IV fluid that mom received. So there's a lot of people who believe that instead of going from the birth weight to see weight loss, we should be going from day 2. So what the baby weighs on the second day of life, that's really after they've peed out that excess fluid, that's really what we should be looking at in terms of what's going on over the next week to assess weight loss or weight gain. And then a late preterm infant, and a baby that is born around 36, 37 weeks may appear to be a full-term baby, but may not act like one. They tend to be very sleepy, slower to latch, particularly the males. They are at higher risk for jaundice and at higher risk for slower weight gain. So a late preterm baby, 36, 37 weeker, really does need extra TLC in terms of breastfeeding support. Okay, so bottom line, if there are challenges in the early days, you kind of have to hang in there. You have to have a contingency plan. You need to have support and keep your eye on the big picture prize. What's most important is that you get the milk moving. You have to establish, initiate, and maintain milk production. Feed the baby what you're expressing a different way because you need a healthy, thriving baby. And you need breasts that are making milk. And so you start off day 1 expressing colostrum, double automatic hospital grade pump preferably, get that milk moving 8 times in 24 hours. That's why my 8 ball is here. That's every 2 or 3 hours during the day, every 3 to 4 hours at night. Feed the baby, get it going, and get some help. So maybe working on breastfeeding and then expressing after breastfeeding, supplementing the baby. You can see the middle picture here. I have Susan is using the hands-free bustier in a pumping style to double pump after she worked on breastfeeding, and then she's supplementing the baby with what she pumped last time as well. If getting into the cycle of working on breastfeeding and then pumping after every feeding and supplementing is overwhelming for you, then working with somebody to develop a reasonable feeding plan. So that might mean that you work on breastfeeding twice a day. You express and feed through the bottle other times of the day, or maybe you're using a nipple shield. So you want to be following up with somebody regarding how to latch with the shield, how to latch without the shield, insurance pumping, and what your longer term plan is. And I put the calendar there to remind you to keep your eye on the big picture because none of these things are, quick and easy fixes, but you have to work through these early challenges to get to the better place because the better place does come. It's just that it can take time. And as long as you have a healthy, thriving baby who's being fed your expressed milk, and you have a breast that is making and maintaining full milk production, then you have, may not feel like the luxury, but you have the luxury of time to put those pieces of the puzzle together. These are all webinars that already exist on the page that you went to get here today, and you can watch these on your leisure. And in particular, I like the slower starts to breastfeeding one for people that are having early challenges. What else? Yeah, there we go. So let's see. Oh, and there's my little friend Brooks over there. I just love that picture. Let me answer these questions and then we'll wrap. Here's one from a mom who says, my baby is 2 weeks old. I've been breastfeeding the whole time and pumping too. Rock on, mama. She seems to still need formula to supplement. Is this normal, and how can I get her off the supplements? Okay, so let's see. I've been breastfeeding the whole time and pumping too. So hopefully some of the suggestions that we talked about today to keep your baby more active at the breast. So sitting up in a chair, not a rocker, using a lot of breast compression and massage while she's feeding, trying to poke and prod and annoy her a little bit while she's feeding, sit her up, burp her, put her on the other breast, use the breast compression, change her diaper in between, really try to keep her going when she is at the breast. If you are expressing after breastfeeding, then you can be feeding her that milk as well. I think what I want to emphasize is actually, is it on here? There's another webinar that I would encourage you to watch that's on concerns about low supply, because in that one I go into normal newborn behavior that or is not getting enough breast milk. So for example, a lot of people assume that the baby should feed at the breast and then they should either swaddle or unswaddle the baby, put the baby down, and the baby will take a nap for an hour or two before the next feeding. When the reality is a baby will fall asleep at the breast, but if you try to take her off, she'll wake up and cry until you put her back at the breast, where she will promptly fall asleep again. And every single time you try to put down a 2-week-old baby, I would not be surprised if within a few minutes she's awake, flailing, screaming until you pick her back up again. So the fact that a baby is not content to be put down and sleep is not an indicator that they're still hungry. And the fact that if you offer them a bottle that they will drink it, again, is not an indicator that they haven't had enough milk. Babies love to suck. If there's milk coming out, it's even better. Babies, especially 2, 3, and 4, and 5, and 6-week-olds, do not want to be put down and left alone. They want to be skin to skin, up against you, and moving. God forbid you sit down holding your baby. They want you standing, walking, and swaying. If you do want to try to put your baby down, your best bet is to, I would say, lay out a swaddling blanket, nurse or hold or walk or rock your baby until your baby's asleep. Put her down and swaddle her snug with the arms down. That might wake her up and make her cry, but now she's awake and swaddled, and you can put her back to the breast, or you can walk and sway and do whatever until she's asleep in your arms, swaddled, and then tuck her against the side of the bassinet so she feels up against and contained by something. Maybe jiggle the bassinet or jiggle her feet a little bit so that her swaddled body is gently jiggled, and that will help her fall back asleep. Now she's swaddled and down, and that may help. Also, a vibrating bouncer seat or the mummaroo or an infant swing, something like that might help too. So they want to be contained, moving, and with you. And that's why I brought up that, because just because she doesn't want to leave the breast or just because she doesn't want to be put down is not necessarily an indicator of not getting enough milk. I would go by weight gain and diapers. Question, how often should we change diapers the first days to determine if it's wet, one wet, or more? I remember with first baby, I found it very hard to count, and baby was having weight issues, so it was definitely important. Yes, that's a great question. It's a very good question, because you could change a baby twice in 24 hours, and is that 2 wet diapers? Those are going to be 2 very heavy wet diapers. I would say that in the early days, day 2, day 3, the volume of wet is pretty small too. So you can also open a diaper and check it, if it's dry. And like we said before, it's hard to tell too if you're using a lot of Vaseline on their diaper region, because the diaper does feel a little bit damp from all that Vaseline absorbed into the diaper. But use that little square of toilet tissue or Kleenex, as I mentioned, and that will help you, that will make it clear if the baby has urinated or not. I would also just go by other cues too, like does the mouth look reasonably moist? Is the baby rousing to eat? Or can you rouse the baby to eat fairly reliably? Things like that. So use diaper changes as a way to wake your baby up as well. I guess I don't have an actual answer for you. I would say, at least 6 times in 24 hours. Some parents may change their baby 10 times in 24 hours. But I would say at least 5 or 6 times in 24 hours. That way, that way you'll know if they're having 5 or 6 wet diapers, I guess. Okay. Last question. I have a question from a mom here who just says, it says 9 months. So if there's a question involved there, you know who you are. Put it in there again, because I don't have it. It just says 9 months. Okay, here's a question from someone that says, feedings are taking a long time, around an hour. Sometimes he doesn't seem satisfied. Do I just keep him on as long as he wants or stop at a certain point? I'm seeing milk in his mouth. Okay, let me see if I can see how old this baby is. Oh, look, Christine is here. This is the first time I've looked at the chat the whole time, and we get to gaze at her beautiful Brooks this whole time. All right, let me see. How old is this baby? I don't know. Feedings can take a long time when your baby's very young. The other thing to remember too is that a baby that's about a month or 2 old, maybe under 8 weeks, so between 2 to 9 weeks or so. Baby just doesn't have any hobbies. You are the hobby. So your baby is probably happiest and most comfortable at the breast and nursing. There's very few places else he or she would rather be. And so hopefully your nipples are comfortable. Massage and compression keep the feeding active. Most babies will stay on and flutter suck for almost as long as you let them. Many babies will not self-detach when they're done. And each time you try to self-detach them, they rouse a little bit and become desperate and fussy to get right back. So that's not surprising. That's where I would use that trick with the swaddle blanket, like I mentioned. If there's some place that you want to go, get your diaper bag and your car seat all set and ready so that you can nurse, poke, prod, massage the breast, etc. Switch sides, change the diaper. In other words, you're really just trying to keep him active and tank him up at the breast, and then take him off, put him in the diaper, not the diaper bag, put him in the car seat and go. Sometimes it's helpful to ask yourself when it's your first baby, what would I do if I had another child? So if you had another child, you would need to go to pick him up at preschool, or you would need to go to the playground or something like that. So if you don't mind sitting on the couch for most of the morning watching TV with the baby at your breast, that's fine. Not only is there nothing wrong with it, there's many things good with it. On the other hand, you do not need to be a slave to only sitting there with the baby at the breast because he has not thought yet to take himself off. Don't expect that he will take himself off each time when he's had enough. It's okay for you to decide to end the feeding, but on the other hand, really trying to encourage him to be active during the first 10, 15, 20, 30 minutes of the feeding, because spending an hour at the breast is mostly taking a nap at the breast. Again, it's not a bad thing. He is still getting some milk, but that's not really feeding for the whole time, even though he's doing that little fluttery suck. Flutter, 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 pause. Flutter, flutter, pause. Yes, he's getting an occasional drop of milk in there, but really what he's doing is dozing and nursing for comfort as opposed to actively transferring milk. So it's not a wrong answer to end those feedings sometimes, but again, don't expect that you can just take him off and put him in the crib and that he'll be happy about that. I'll also mention baby wearing, because this is absolutely why it's nice to put the baby in a sling or a carrier or a wrap for when you're puttering around the house, because your baby will not be happy being put down, but may be happy being worn, and sometimes we'll take a nap that way, a nice long nap that way. Okay, I think we got to get going. I did go long today, so thank you for sticking with me. Hillary, thank you so much. Please come back next week. I'm happy to take suggestions on topics to cover as well. Let's see. I wonder if, I think probably next week I'll just do all Q&A. And then I'll set up some topics for the next few weeks after that. Please take a look, browse all of the topics that we've already covered and have archived there. Come back next week. Of course, every Tuesday at 12 noon, we do our sleep webinar with Meg. If you don't already receive the IsisParenting e-newsletter that comes every Tuesday morning, it's done by age and stage. So if you have a toddler at home and you're expecting a new baby, for example, make sure you register for both. So you'll get you'll get one that's tied in with the exact week of your pregnancy or the exact age of your infant or toddler, so on. Thanks, everybody. Have a great week. Bye-bye.